Thank you very much. It's nice. First of all, I would like to thank the organizer, Dr. Wiam, and Dr. Khalid and the organizing committee for inviting me to give a talk on what I think it's a challenging topic that we all facing at this stage. The topic entitled T4 T3 combination. Where do we stand at this stage? So the objective here is to first to present to you the evidence comparing combination T4 T3 therapy compared to monotherapy with T4, and to explore recent development and emerging approaches in thyroid hormone replacement therapy, and maybe to stimulate from the audience discussion based on personal experience and based on cases that you have encountered. Now, before we go further, those therapies are directed to address patients with hypothyroidism. Just quickly to remind everyone that hypothyroidism is well established, that is a condition caused by insufficient secretion of thyroid hormone, leading to subnormal circulating thyroid hormone levels and disrupted tissue signaling. Obviously, the most common cause is autoimmune destruction of the thyroid, Hashimoto's, thyroiditis, surgical removal of the thyroid or thyroid gland ablation with radioactive iodine therapy, accelerated clearance of thyroid hormone beyond compensatory thyroid secretion if you're using some drug that enhances the clearance of thyroid hormone, and finally, less commonly, genetic defect in the thyroid gland. Now, we know that there is a plasma tissue balance that's really very, very effective in maintaining the plasma, maintaining the concentration of thyroid hormone within tissue in balance. So, but unfortunately, we have situation where this is really not happening, such in iodine deficiency, where you have like an imbalance. You have the gland is pushing to compensate for the lack of conversion of the lack of T3 in the tissues. So you have increased conversion of T4 to T3, which is seen in some endemic areas. Now, the symptoms are important in recognizing mood changes, cognitive impairment, and metabolic disruptions due to insufficient thyroid hormone signaling, and the impact is really important, and that's why treatment has evolved over the years. And for this reason, I might take you for a little bit of history to take you from the 1800s to the current time, how this has evolved all along. This is really quite interesting, and to make it a little bit easier, I took it step by step. So the first recognition of myxedema as a clinical syndrome happened essentially post-myxedema, post-thyroidectomy myxedema, and that's where they linked that picture that you see in the screen to hypothyroidism. And the initial attempts were really either using, having raw thyroid consumption from animals or putting some extract in the subcutaneous tissue, but obviously none was effective. And then it came the early 1900s, and then this is where we've seen the initial diagnostic and the tools, and the only one was available, basal metabolic rate. And they counted so much on that that they made a classification of severity based on the BMR. But again, this is really was not very sufficient really to, it was limited and was ineffective to monitor patient as far as therapy is concerned. Then came the 1920s, 1930s, and we saw the appearance of natural extract therapy. The thyroid extract, which was used inappropriately before, that got standardized, and chemical isolation of thyroxine occurred in 1926. And oral desiccated thyroid therapy begins, guided clinically and biochemically, biologically by BMR. But again, this has evolved with the synthesis of crystalline levothyroxine, and then the subsequent initiation of trials, and using this time, along with the BMR, a test in the serum called protein-bound iodine to assess for thyroid function. This is also was not sufficient and not conclusive. And 50s, 60s, it was the identification of T3, which was isolated in 1952, and the initial trial comparing levothyroxine with desiccated extract. And the early trials where we have seen combination of T4, T3 with, compared to T4. Now, the best period was between after 1970 till the 2020, where we started understanding what's happening truly, that T4 is converted to T3 at the level of the periphery, and there is feedback that's really occurring. And then at that time, more precise testing for thyroid hormone occurred using radioimmunoassays, which was launched in 1971. So this is a great evolution that has happened, and it took really the best toll is when levothyroxine became standard treatment. And it's interesting, it became standard treatment without going for randomized trial, and was accepted by the authorizing societies without really going to the restriction that really every drug is going through at this stage, because it was so miraculous and going excellent results. And TSH became as the primary monitoring biomarker. And since then, we have seen a flourish, a ground for observational studies, randomized studies that looked at the combination, comparing monotherapy with combination therapy. Now, at this stage, I will come back and to summarize some of those studies, but up till 2022, the guidelines were not so much in favor of using combination therapy. The ATA in 2014 routine use is not recommended, only to be used if symptom persists despite abnormal TSH. And this is based on weak evidence, and careful monitoring is needed. So cautious also to do it on a trial basis and to stop if really symptoms happen. The ATA in the initial version 2012 and then subsequently 2021, routine use of this combination is not to be used, and only use it if after shared decision making with the patient. And again, preference is made for not the desiccated thyroid, but for the T3, the synthetic T3. The BTA in 2022, again, not recommended, short-term trial in selected cases only, and emphasis needed for research, and again, cautious use of this combination. So, to answer those really, and those guidelines were based on a study really done by Millen and Alandis, who and his group that summarized most of the randomized trials that really were happening between 2000 and 2020. So they looked at the benefit and harms of the combination therapy versus monotherapy. And they did a systemic review, a meta-analysis of 18 studies, including 1,563 adults with hypothyroidism. The key findings, no clear difference in clinical outcome. Higher patient preference for combined therapy perceived by the patient, 43% versus 23%, and adverse effects were similar in both groups, which is really interesting. I mean, I thought that the adverse event will be higher with the T3. Combination, take-home messages that consider combination therapy for patient unhappy with LT4 alone. And the group really of those patient unhappy, I don't know what percentage you perceive in your clinic, but in the literature estimate to be around 20%. So it's not insignificant, it's there. And in the clinic we perceive it. And so more research they felt is needed, longer trials, because they felt that the maximum trial did not exceed 6 months, and then the dosing of the combination was variable, going from a ratio of 4:1 to 14:1 of T4 to T3. So there was a significant heterogeneity among those studies, and but the good thing, they highlighted that maybe genetic factors, for the first time, could be involved at this stage. Now, as I mentioned, but again, despite the guidelines, patient resisted the guidelines, some patients resisted the guidelines, and some of them actually came and organized petitions to maintain the production of desiccated thyroid because they were not happy by using only T4. And so there was a push from the patient to have more randomized trials to explore this point. Especially that some physicians perceive that there are scientific evidence now that emerging that is indicating that truly there is some issue with some patient that they're not producing at the level of the tissue enough of T3. And this is, again, as I mentioned, in iodine deficiency, the body is pushing really to use all the T4 available, but sometimes it becomes insufficient if you're dealing in iodine deficient area. So there is still perceived low T3 tissue with associated symptoms. Again, if you look, when they look at the level of the pituitary cells, the deiodinase responsible for the conversion of T4 to T3 is more efficient than the deiodinases at the level of the peripheral tissues. So by the time you get enough T3 to feed back on the pituitary to say that I have enough of the T3, the conversion at the level of the peripheral tissue still has not been completed. So we end up with normal TSH, normal free T4, but T3 is still on the low side. Another thing is that that's the time they identified that some polymorphism in the deiodinase 2, and they identified a common genetic variant, tried 92LA, which can reduce the T3 activity and affect therapy response. So some have deficiency in producing inefficient deiodinase, so they'll have lower T3. And again, if you look at the way that the thyroid hormone gets inside the cells, this is done through specific transporters. And there's polymorphism in thyroid hormone transporter, and some mutations, like the MCT8 mutation, gene mutation, can impair the T3 delivery to tissue, and causing on one extreme the syndrome of Allen-Herndon-Dudley, which you have short stature, deafness, and severe hypothyroidism, to the other extreme where you have mild fatigue because there is mild deficiency of those transporter, like mild fatigue and cognition issues. Now, on that basis, there was a strong push for some expert to join effort from the ATA, the BTA, and the European Thyroid Association. So 12 experts gathered together, and they reviewed 11 topics, and they came up with 34 statements. And the high agreement was only in 28 of those. The other ones were only of some disagreement on it. So from the key messages that you have to take from, there's 3 items they identified, that they realized that T4 alone does normalize really TSH, but not always. It normalizes T3 in tissue. And that the combination may benefit some patients. So they recognize this fact. And there are genetic variants that can affect outcome. But unfortunately, they highlighted that the studies have to have 2 major criteria. 1, they have to be randomized. 2, they have to be of long duration, at least 12 months. And then 2, there should be some harmonization in the ratio of T4 to T3 use. Not in the previous study where there was so much diversity in the ratio being adopted. And then that, which is most important, they highlighted that the patient-reported symptoms do matter and the patient should be taken into account in any study that being performed. So they should be part of the organizing committee. So here came some clinical trials, and many came after 2022. I selected the one that they looked at mainly randomized trials. So this is from Land, where they looked at compare psychological outcome of the combination versus monotherapy. And for this, they did a systemic review and meta-analysis of 18 studies, which include 883 patients. The studies span from 2000 to 2021 of patients with overt hypothyroidism, more than 18 years of age. Now, the key result here is that the symptoms that we see frequently in hypothyroidism, like depression, fatigue, pain, and anger, they thought that the result indicated that there's no benefit of the combination versus monotherapy. Again, highlighting this point again. But again, it's coming in every study. The patient perception that they prefer T4, T3 combination better than the monotherapy. And the relative risk was 2.47, which is really significant. Now with the T4, when you look at the other parameters like TSH, lipid, BMI, weight, or heart issues, again, they didn't find any difference using combination or monotherapy. You would have thought that there will be more heart issue using T3, but it looks like really that this did not happen. And when you look at the profile that you have biochemical profile, you have lower T4 or total T4 and higher T3 when you do the testing on the patient. So the conclusion, T4 monotherapy is equivalent to standard therapy with combination. Combination therapy to monotherapy is equivalent. Consider T4, T3 combination for, again, dissatisfied patient. But again, you have to share the decision with your patient, which is really essential. Another one looked at by Nassar. Nassar, it's an Egyptian study. I thought that we should look into the region. Okay, and then again, a randomized study, and again, they looked at systemic randomized 600, 394, and again, the result is the same. No difference between clinical, between combination therapy and monotherapy. The Levolio study, again looking at combination T4 and T3 therapy in thyroid patient who had thyroid surgery, which is really where in my clinic I see it more frequently. That's the patient who goes to undergo surgery and followed by radioactivity. Those the one that complained by constant fatigue and tiredness. Again, no added benefit of LT4, LT3 for most endpoints. Combination therapy for them remains experimental, but may help for patients with persistent symptoms despite normal TSH. Again, treatment preferences in patients. This is a study from Brazil and Salvador. Again, they were a little bit more optimistic in the sense that there is a place to use combination therapy, and they were accused by being biased in the sense from the start that's the aim that they had to show. And they restricted their study on one specific population, which is the Brazilian and the North American population. And there was not the ethnic diversity, and then the subjective preferences were again highlighted. So finally, just as the last study, again, this is looking at the safety. This is a very comprehensive safety study looking at safety, looking at published studies from 2,441 patients in randomized trial, and looking at the real-world report from Merck Global Pharmacovigilance Database, including more than 1 million reporting incidents. And again, the key safety finding, no major safety concern. Small heart increase, 2 to 4 beats with high T3 dosing, even with the ratio of 4 to 1. and the similar adverse event rate as T4 monotherapy in both groups. And the real-world data, again, very similar. So it seems that overall, still there is no consensus on using combination versus T4, but again, there is the safety margin seems is acceptable if you follow your patient cautiously and you do a proper selection of your patient. So what's in the pipeline? Just 2 minutes extra, I'll take it just to tell you what's been cooking there. The ATA, despite in 2014, acknowledging that really they don't really promote the use of combination T4, T3 versus mono, but they indicate that there's a need for the use of slow release T3, which will make things a lot more evident and avoid complications that might emanate from T3. And for this, there was some attempt using some modified T3 molecules, like adding sulfate groups to the hydroxyl group on the amino acid on thyroid hormone, or attaching some zinc to the T3 moiety. So in the sulfated form, when you absorb it, it gets into the blood, it's slowly absorbed, and will not get absorbed until it gets into the liver, where there is a large number of sulfatases. So that sulfate is being taken away, and the 3 gets to be released slowly from the liver and creating a steady level. Some experimental studies have been quite interesting, and some human trial will probably be coming soon. For the polyzinc T3, it has a different mechanism because it's zinc, it's really heavy metal. So once it gets absorbed, stick to the gut, and then from there, the bacteria act on that complex and release T3 slowly, and it gets into the blood in a very easy and slow and sustained way. In this regard, there is a just recently published, actually, a study by Azizi group from Tehran, where they looked at 32 hypothyroid women, aged 30 to 60, and one group, they give them T475 with with slow release T3, 15 microgram. The other group only T4, 100 microgram, the trial for 4 months. And they looked at some inclusion criteria indicating the significance of the hypothyroidism. They excluded some patients with illnesses, specific illnesses, pregnancy, medication affecting thyroid. And their result were actually, maybe I'm missing one slide, quite good results. Actually, they found that patients who had the combination, when they used the ratio of T4 to total T3 to free T4, which is it's an indication how effective the thyroid hormone are doing, they realized that actually they reach the same level as normal, physiological normal level. So this is reassuring. And with this, maybe I had one other things to mention, that some other trials have been using specific T3 formulation going and affecting specific tissue, not really all tissue. So, like in fatty liver, some of the T3 formulation, they have been targeted to affect the fat metabolism and lipid metabolism at the level of the liver. And then that's why we're seeing now more trials in fatty liver using special forms of T3. And with this, I maybe stop at this stage. I think I passed my time to indicate that at this stage, still no consensus on the use of combination. If you have to use it, you have to use synthetic T3, and if you have to use it, you have to split your dose during the day, not only with one single dose of T3, otherwise you're going to have very high peaks. There is hope that really that will be, slow formulation will be available, and the future is coming up with other formulation will be of great value. Thank you very much.